May I call upon stage Dr. Sunita Sharma, and may I request Dr. Mamta Soni to chair the session, please.
Good evening, everyone. It's my privilege to introduce Dr. Sunita Sharma, who is a consultant pathologist with Wadia Hospital, Mumbai. She's a trained medical staff under IDSP, under DHS and UT Health Mission in 2018 and 2022. She had shared sessions among experts for expert comments in national level conference for PRBC, that is Pediatric Rare and Complex Benign Hematology Conference on a case of congenital TTP held in Mumbai on June 2023. So I welcome you, Dr. Sunita, and over to you. Thank you.
Thank you, ma'am. And first of all, I would like to thank Mindray and the organizers for giving me the opportunity to present here. My study is based on a different kind of population. It's on newborns, mainly neonates. And this request came in the same PRBC conference. One of the neonatologists asked me, I need IT ratio. How can you report to me how I should send the request? Then I said, let me study. It should not be a big problem because we have hematology analyzers which are capacity to report so many parameters. But I asked some time from her, and then I started study so that I thought, can I give the report to all the patients or only selective where requests are asked? So this is the study about the IT ratio, a predictor of septicemia in pediatric patients, and role of hematology analyzers. So I studied how much analyzers can help this kind of population. Since it is a pediatric hospital and a huge ICU, and ICU has a largest ICU in our hospital, 155 bedded, where 40 beds are ventilator assisted. So first of all, what is the septicemia? The definition wise, neonatal sepsis is described as a suspected or demonstrated infection in newborn, a systemic inflammatory response syndrome with variable sign and symptoms caused by pathogens with or without accompanying bacteremia. Neonatal sepsis is divided in two types, early onset within 72 hours and late onset, which manifests after 72 hours of birth. It's a leading cause of mortality and morbidity worldwide in middle and lower income countries. The overall mortality rate is up to 24.4%, but it can be as high as 30% and 54% in premature and very premature in infants. Neonatal sepsis incidence is 30 per 1,000 live births, whereas community-based studies indicate incidence as high as 2.7 to 17% of all live births. Septicemia risk factors are generally prematurity, premature rupture of membranes, low birth weight, birth asphyxia, congenital anomalies, etc. These various screening tests used for the diagnosis of sepsis are generally within 6 to 8 hours are WBC count, whether high or low, platelet counts, ESR, absolute neutrophil count, C-reactive protein, IT ratio, which I'm going to discuss, nitro-blue, tetrazolium test, serial interleukin 6, and procalcitonin. TLC low or high, immature to total neutrophil count is IT ratio, which cutoff is more than 0.2, which indicates the child is going to have septicemia. So for IT ratio calculation, we need hematology analyzer and the parameters related to neutrophil. How I compare this study is with the gold standard parameter, that is blood culture. The result of blood culture is available after 3 to 5 days and the accuracy varies between 8 to 73%. So IT ratio can give within a day or two that first day we get the sample of CBC, we can report that this particular child is going to have septicemia or not. So early diagnosis is a key. It helps to the pediatrician for timely antibiotic therapy, and it also helps prevent emergence of resistant bacteria. Early decision can reduce infant mortality. Hence, the study was designed to test the diagnostic accuracy of IT ratio for early onset sepsis and its comparison with blood culture and other tests. In a prospective, this was a prospective study. I got the request in the June month and I did this in the July month for 1 month study. The in a prospective study in neonates, generally it is found that high NP, negative predictive value of CRP and IT ratio in early and late onset infection is up to 90 to 98%. The sensitivity of IT ratio had ranged from 60 to 90% as per the literature. The elevated IT ratio values is considered in conjunction with other clinical signs for confirmation of neonatal sepsis. Few previous studies concluded that IT ratio more than 0.8 fairly approximates with the neutrophil storage pool in bone marrow, thereby saving the neonates for bone marrow examination. The ratio is quite helpful in identifying newborns who might be benefited with GCSF therapy. So our aim is, since it is a rapid, simple and readily available test, this study aimed to re-evaluate the usefulness of neutrophil left shift, immature granulocyte percent and IT ratio for the diagnosis of neonatal sepsis and assess its prognostic value. To calculate and establish IT ratio utility as an early onset sepsis predictor. To utilize hematology analyzer for the calculation of IT ratio and determination of cutoff as sepsis predictive marker, and to correlate IT ratio with culture study results, to correlate with the manual method, IT ratio calculation by machine versus manual. The parameters we took was IMG percent, shift to left and total neutrophil percent. The methodology what we used study was prospective observational study. Study duration was 1 month. July 2023. Inclusion criteria, the patients whose CBC count and blood culture sample we received were included and those one of them is not received were excluded. Sample size was 70. Results were recorded and analyzed as per MS Excel based software. Statistical analysis for the correlation was done. So method for IT ratio, as all knows, it's a percent of immature neutrophil divided by percent of total neutrophil, which includes mature plus immature. This formula can be fed easily in the LIS system and directly results can be given to every patient. Flags, we check the flags given by the machine as shift to left or IMG percent. And based on that, we can decide for the manual count of peripheral smear for differential count, and then we calculate manually also. This is the flow chart which I followed. Blood culture request sent along with the CBC. Then CBC was processed in the hematology analyzer. Analyzer flags were checked for IMG percent and shift to left. And based on that, peripheral smear examination was done for manual DC. Here I did the manual DC because I wanted to compare from the machine versus manual. So for every case, manual smear was made. And formula was used to calculate machine value using IMG percent and manually differential count IMG plus total neutrophil count. This is the machine screen is showing shift to left and IMG percent, and in smear examination we saw the band cells which were not given in IMG percent by machine. So to calculate those band forms in immature granulocyte, manual count was required. Leukocyte counts were done on Mindray Hematology cell counter in the lab. Differential including immature neutrophil count were performed manually after making suitable thin film smears by senior lab technician. IT ratio also calculated using IMG percent by machine. Only IMG percent divided by IMG percent plus neutrophil percent. That was machine count, and manually differential including band cell plus IMG, whatever immature granulocyte we get in the differential smear, in the peripheral smear, divided by total. The same time, inoculated blood cultures were incubated at 37 degrees for 5 days. Negative culture reports given after 5 days. Positive flag culture bottles were subculture as per the SOP of microbiology. So we had 70 cases. Positive by culture were 22 and negative were 48. So average IT ratio manually, we are mainly concerned with the manual, but comparing machine. So IT ratio was going more than 0.245 plus minus 0.155, while by machine it was 0.03 plus minus 0.06. While in negative culture, manual method, you can see the value is very low, 0.096. And by machine, it is even lower, 0.025. And same time, I also analyzed CRP values, but CRP values were not available for all the patients, so data is lesser. 16 cases, here I just want to highlight that positive culture had high predictive value. 16 cases, blood culture positive, out of them 15 had CRP positive. I would like to show the tabulated form for a negative and positive culture with IT ratio and CRP values, and show other way. This specificity is for true positive is sensitivity is 63.6%, this is true positive, and specificity is 89.8%, around 90%, and the negative predictive value for IT ratio 0.2 is 84.3, quite high, it's quite significant. This is the graphical representation. Here we can see the culture positive and negative cases. In culture positive, IT ratio, you can see the cutoff is 0.2, and most of the culture positive cases, you can see the cases totally in the x-axis, they are all above 0.2. While for negative culture, IT ratio is below 0.2. This is by manual method. Then this is the machine method. Because machine bands are not counted in immature granulocyte percent, the cutoff value is very low. It is below 0.2, while for manual method, most of the cases showing cutoff value above 0.2. CRP values, we had very few cases CRP value available. We can see positive cultures showing, most of the positive are showing CRP value positive, while negative are showing low values, negative CRP. So the present study revealed that IT ratio showed high specificity, around 90%, and high negative predictive value, around 85%. This study depicts the role of low IT ratio as an indicator to exclude early onset neonatal sepsis. This is in agreement with the previous studies which displayed NPV in the range of 90 to 98% for IT ratio more than 0.2 in excluding early onset sepsis. This study accounted only for neonatal sepsis, short duration of study, and tertiary apex reference pediatric hospital with 155 bedded NICU. Present study revealed that even simple hematological ratio can help in ruling in or ruling out early onset sepsis, thereby decreasing hospital stay, alleviating the anxiety of parents, and help preventing development of antibiotic resistant pathogenic strains. This is especially important for various resource limited clinical setups. Total leukocyte count is not correlating with the positive culture for neonatal sepsis diagnosis, as majority of patients had normal counts. Automated calculation for hematology analyzers as sole interpretation should be avoided till further advancements are done. Till then, manual peripheral smear examination needs to be done. This is our study. Compared with other previous studies, the data are almost similar. So to conclude, IT ratio is a useful tool for early onset sepsis with reasonable specificity but cannot be relied upon as a sole indicator. Combination of normal IT ratio with negative CRP value in neonate is an indicator of non-infected neonate. IT ratio may be good alternative to blood cultures for neonatal sepsis as it is faster, less expensive, and has good sensitivity and specificity. IT ratio is a promise as a novel, effective, simple method to screen sepsis when used in conjunction with ANC and CRP and does not require special laboratory facilities. Further studies with improvement in method for detecting immature granulocyte and well-defined reference intervals are required in automated immature granulocyte persons. The limitation we found, we had only few infants with positive blood cultures. When calculating sensitivity and specificity, the new result is compared with the blood culture, a method which has its own limitation with for both sensitivity and specificity. The study included material from a single tertiary care reference center. This increases the risk that the result only reflect the local situation. If analyzer counts band cells with IMG%, then formula can be fed in the LIS and reporting can be faster and error-free as manual counting variability can be minimized. Area of improvement and not limitation. So our recommendation is to integrate the calculation formula of IT ratio in hematology analyzer through LIS for faster reporting of results for sepsis prediction. The machine needs to learn about the shift to left and IMG% better for direct calculation of IT ratio. These are the references. Thank you.
Process.
Yes, there is a variability inter-observer. That's why the shift to left is the amount of band cells not given by the machine. If it gives, it can help much more because directly we can fed the formula also within the machine or in the LIS and directly can be reported to all the pediatric population.
Yeah, so again, yes, so the automation will help in that.
Yes.
Fine. So, any questions? Yes, ma'am, please.
Thank you so much. Very nice work, very good presentation.
Thank you, ma'am.
I'm very glad that you brought out the problem of the analyzers in not recognizing band cells.
Yes.
Now, even Stanford Hospital, and we have been doing that. We manually count, they have also made a rule, slide review criteria for all neonates for diagnosis of sepsis. Because so far, none of the analyzers can measure band cells. They Mylo, Meta, Pro, yes, but band cells they don't. And we have been doing also the same thing manually, but you are taking the negative predictive value as more important as ruling out sepsis. We have been working on the positive aspect of it. What we do is, of course, manual band cell to neutrophil ratio, but we have added eosinopenia to that formula. And if you start looking at that, you will realize even your analyzer will give you either no eosinophil or very low eosinophil, 0.01, 0.02. Start looking at that. You will see, you will be able to predict sepsis. Instead of saying no sepsis, you will be able to predict sepsis, but only on band cell neutrophil ratio. And I look at the eosinophils along with it. But I'm very glad you brought this out. I've been talking to all the analyzers. कि आपकी machine band cell क्यों नहीं count करती? They can't do it because it is basically neutrophil only. That's it. Thank you so much.
Yes, ma'am. And the band, even shift to left was given only for 3 patients here.
Yeah, and in a busy lab, it is actually whenever we get a request from the pediatrician to calculate a band neutrophil ratio, we hate it because it is so time consuming and it is also a lot of inter-observer variation. Yeah.
Though it's a helpful parameter for septicemia diagnosis.
Yes, yes. So yeah, food for thought for Mindray. Give us band cells. Yes, sir, please.
No, I have to say my opinion about bands. Because when I go to the international meetings or the ICSH, and they treat me like crazy when I say that bands are useful. But I have to be objective. I have done studies with sepsis in neonatal sepsis, including bands or not, only in mature neutrophils. And when you include the bands, the ROC curve and the sensitivity increase dramatically. And are the facts. I cannot go against the facts. And the fact that bands statistically are better to be included or not. And they say, but they have a lot of variation. Yes, but metamyelocytes have a lot of variation between also observers in the microscope. And they are in less proportion. For this reason, even with a low number, have more variability between, for this reason, but there is a fashion. And of course, no any company can go against the 95% of the laboratories in the world that they don't report bands, they don't give bands. But honestly, my opinion is bands are useful.
Yes.
Yeah, even RCPA morphology and bone marrow program, it doesn't differentiate band. You can give band plus neutrophil together.
But I have a good news.
Yeah.
The MC80 include bands.
So,
The MC80, the digital imaging include bands.
so thank you, Dr. Raman. Any other question, comment? If not, thank you, Dr. Sunita, for a very informative and detailed presentation.